Okay, I'm delighted, happy, looking forward. Last lecture of the semester, and for you too, last day. Okay, this lecture is heavily dependent upon your understanding of pathophysiological basis of breast cancer. So I assume you have enough background of pathology. Drugs used in breast cancer. We'll discuss the treatment approaches in breast cancer, rationalize pharmacotherapy in management of breast cancer, pharmacology of various drugs. Okay. Now, I assume you all have the file with you. Okay. So no need to ask questions because you can read from the slides. Treatment approaches in breast cancer, obviously depending upon the stage. While looking at the patient, investigation, overall, you will make an objective. What do you want? Is this a curable stage where you can achieve a cure? If yes, you will approach the patient differently. Sometimes it is not curable, then your approach will not be the same. Your approach will be then how to make the life of the patient as comfortable as possible, or even how to prolong to buy some weeks or months for her. That's it. So that type of approach is known as palliative intent. And when you want to cure the patient to get rid of the disease permanently, then that approach is curative intent. Okay, depending upon the stage. So curative intent and palliative intent. Accordingly, the treatment will differ. And this depends upon the stage and type of the disease. Okay, treatment modalities, we have surgery, we have radiation therapy and pharmacotherapy. Pharmacotherapy, there are sub-headings of pharmacotherapy, chemotherapy, non-specific cytotoxic drugs, chemotherapeutic agents, which we have already covered in POD and other blocks. We'll repeat some of the drugs. Hormone therapy, very, very specific for breast cancer. Targeted therapy, once again, very, very specific for breast cancer. And bone-directed therapy, this I have added as additional slide to tell you that in addition to the specific anti-cancer drugs, sometimes you require drugs as an adjuvant therapy to treat some consequences of the breast cancer. We'll discuss the last one slide. Surgery, clinician has covered briefly. This is none of my domain, but just a brief recap. The aim of the surgery is to remove breast cancer and adjoining normal tissue around the cancer. Depending on, once again, the extent of the cancer, there are various types of surgery. Breast conserving surgery, which is also known as clinician has told you one other term. Do you remember lumpectomy? This is lumpectomy, partial. Then the lump tumor, along with some margin of normal tissue around it, is removed. Okay, this is breast conserving. Of course, it will be the stage 1 disease. Total mastectomy, complete removal of the breast along with the skin. Skin sparing mastectomy, this modality is when immediately during or after the mastectomy, another surgery is in planning. You have planned another surgery, which is you spare the skin, you remove the tissue, breast tissue, complete tissue, but that skin sparing modality surgery is done when immediately after that surgery, mastectomy, your plan is to have reconstruction surgery to conserve breast. I mean, breast tissue will be removed. Our breast is, I mean, aesthetically, breast is required for the females. So in that case, immediately after the mastectomy, some women go for the prosthetic breast tissue, like silicone and other things. There are prosthetic tissue. So skin is removed. Skin is spared, sorry, not removed. Skin is spared. Adjoining breast, I mean the complete tissue is removed and then it is filled with some prosthetic tissue. So this is known as reconstructive surgery. Okay, and finally, radical mastectomy is done when there is involvement of the regional lymph nodes. So removal of breast tissue along with some of the skeletal muscle like pectoral muscle underlying and then along with regional lymph nodes, radical mastectomy. Okay, this is none of my business. So clinician must have told you. Let's go to the other things. Radiation therapy, I am not involved. Surgery, radiation, I am focused on pharmacotherapy. Okay. Pharmacotherapy can be adjuvant and can be neoadjuvant. If you remember the lecture in POD, you must remember what is adjuvant and what is neoadjuvant and what are their objectives. Raise your hand if you remember the adjuvant. Yes. No, no. Someone else, adjuvant. Adjuvant before surgery. Before surgery. Before surgery. Adjuvant. Neoadjuvant before surgery and neoadjuvant after surgery. Okay. The objectives are different. Of course, whatever the modality, imaging or diagnostic modality you have, there is always a chance that after MRI, mammogram, or histopathology, or with your open eye, whatever you see, there is always a chance that some cancer cells are still remaining. The objective is to remove all the cancer cells, malignant cells from the body. So in early stage disease, you perform surgery, mastectomy, but there is still a chance some malignant cells are remaining. In that case, after the surgery, drugs are given. The objective is to mop up to get 100% clinical cure, pathological cure also. If the cells are remaining, they can be killed by the pharmacotherapy drugs. That is adjuvant surgery followed by chemotherapy. Neoadjuvant, when the tumor is of good size and the surgery may be difficult or you want to have similar surgery, the incision should be lesser. So the objective now is to shrink the size of the tumor as much as possible so that after the treatment, the surgery performed is as small as possible. In the case of breast, it becomes very important because breast is very, very important issue for the females, isn't it? In that case, removal of the breast tissue, smallest possible resection will be more appropriate, isn't it? In that case, neoadjuvant will be, the objective is to shrink the size of the tumor as much as possible so that the breast tissue removed is as small as possible. Did I get? Did I make myself clear? So it can be adjuvant or neoadjuvant. Fortunately, because of the awareness and other things, even a small lump may warn the patient. So nowadays, most of the, 90% or more, breast cancers are diagnosed at very early stage. At that time, they are curable. Most of the time, the intent is curative intent, not palliative. So treatment is possible, especially with the advent of new targeted therapies. Because the The outlook is very, very promising in case of breast cancer nowadays. Adjuvant systemic therapy improves survival. Adjuvant chemotherapy for patients with either node positive means lymph node positive, or a higher risk when hormone receptor negative or HER2 positive, node negative breast cancer. Oh, which one is based upon clinical lectures and pathology lectures? Which one is that carries worse prognosis? Estrogen receptor positive, negative, and then HER2 positive. Okay, I give you three scenarios. ER positive, HER negative. ER negative, HER positive, triple negative. In that case, which one carries more risk? Poor prognosis. Triple negative, followed by HER positive, receptor negative, followed by receptor positive. Receptor positive is carry less risk, isn't it? You know already know. So endocrine therapy, adjuvant therapy for all receptor positive cancer cells. Hormonal modulation decreases. Okay, this is clinician was stated. Let's directly go to the drugs. New addition. Pharmacotherapy, 4 modalities, 4 subtopics. Chemotherapy, hormonal therapy, targeted therapy, and bone-directed therapy. We'll discuss one by one. Now, chemotherapy are the drugs which we have already covered in BOD and subsequent classes. Doxorubicin, familiar? Okay. Cyclophosphamide, known. Paclitaxel, known to you already. Hello. And POD. We have covered. Okay. You have forgotten. Okay. Methotrexate many times. Okay. And fluorouracil. Okay. So these I have selected 5 drugs which are most commonly used in various drug regimens. Can be neoadjuvant, can be adjuvant. One by one, briefly. Doxorubicin, do you remember? Cardiotoxic, but what is the mechanism of action? Okay. It is antibiotic, anthracycline antibiotic, and obtained from Streptomyces bacteria. So it is intercalating agent. If you remember intercalating agent, intercalating means something. If there are 2 layers, for example, DNA or 2 sheets adjacent, something, the common English phrase is something sits in between. Okay. While sitting in between, if there are 2 chairs, and you sit here just like chairs, legs on one chair, and you are sitting, what will happen? You will occupy that seat completely, and nobody else will be able to sit on both seats. Both seats are occupied completely. So that is intercalation. Something sits in 2 layers, between 2 layers. Intercalating agents. So doxorubicin or anthracycline antibiotics, they are intercalating agents. They sit between 2 strands of DNA. What will happen? During DNA replication, the role of topoisomerase, it has to cut and seal to remove the superfiles that cannot find the seat to do this. Because I'll show you the figure, I think I have made it already. No. Oh, yes. Here you can see. So doxorubicin molecules sits between 2 strands of DNA. Topoisomerase cannot find a place to remove the superfiles. So DNA replication is completely halted. So by virtue of intercalating between 2 DNA strands, this antibiotic doxorubicin causes inhibition or disruption of DNA replication. Am I clear? We have discussed already. So whatever we discussed, it is already mentioned here in the bullet form. You can read on your own. The last bullet, it is phase non-specific. Why it is non-specific? Because the DNA replication happens in all cells during all stages. But most active in S phase because it is during that phase when DNA replication is at its peak, at its maximum. Is that clear? Anything else? That's it. Okay. Adverse effect, somebody mentioned, you only remember the side effect. Cardiotoxicity, it is causes dilated cardiomyopathy and ventricular arrhythmias. And it's very specific side effect of doxorubicin. And cardiomyopathy may be prevented by a drug, dexamethasone. It is a drug which can be given. There are many drugs which, when given along with anti-cancer drugs, can prevent. For example, in case of methotrexate, if you remember, I told you one drug can prevent the bone marrow depression, severe bone marrow depression caused by methotrexate, a drug. Miss, no, folinic acid, leucovorin. I asked the question in the exam also. Okay. Here in this case, it is dexamethasone, which can prevent the cardiotoxicity caused by doxorubicin, myelosuppression, alopecia, typhlitis. These are the side effects we already have discussed many times in the past. Cyclophosphamide, another drug we have covered many times. Do you remember the mechanism of action? Alkylating agent. Okay, very good. So it is a special attachment, it cross links within DNA and between adjacent DNA. A special position is G and 7 position. And then with this cross linking, once again, the DNA is unable to replicate. Once again, the same statement, like although cross-linking agents are dependent upon proliferation, these agents are not cell cycle specific because the alkylation reactions that initiate cell death can occur during any phase of the cycle. The same statement which I made in the previous. Okay. Adverse effects, you remember? One side effect, hemorrhagic cystitis. Okay, we also asked a question in the exam, I remember, hemorrhagic cystitis. And one drug which can prevent that hemorrhagic cystitis is Beslan. So this is just a repetition of what we have learned already. You can ask, you can read, and if you can ask question if the things are not clear. Should we move? Good. Now, majority of you think that this is a new thing. I'll give you a hint. There are some drugs which are classified as mitotic spindle poisons. They are poisons to mitotic spindles. Let's go further. Mitotic spindle is made of tubulin, but over the broad way, it's the microtubules. Microtubules are made of, they are polymers of beta tubulin. Am I right? Tubulin. And the role of mitotic spindle is beta tubulin has to polymerize to make microtubules, which is mitotic spindle. Initially, it has to pull apart the chromosomes. They have to separate. In order, after the pulling separation, the microtubule, mitotic spindle, has to depolymerize. Initially polymerize to make microtubules, then it has to depolymerize to release it so that each chromosome should go to its daughter cell. Is that clear? So two processes are required. One is polymerization of beta tubulin to make mitotic spindle or microtubules, and then finally, for the completion of the whole process, it has to be depolymerized. So there are two classes of drugs, which first they inhibit the polymerization of beta tubulin, and there is another set of drugs, class of drugs, which inhibit the depolymerization. Now, polymerization, you remember. You know, Vinca alkalides, vincristine, vinblastine. Now, you remember? They inhibit the polymerization of beta tubulins. Now, taxanes, paclitaxel is one of them. They are the drugs which inhibit the depolymerization. Together, both of these classes are known as Vinca, mitotic spindle poisons, because they arrest the cell division during M phase. They are cell cycle. Now, just on a lighter note, there are some other drugs which also have effect on the polymerization of beta tubulin, but they act differently. One drug is anti-helminthic drug. You studied. No? Anti-helminthic. Metronidazole is not anti-helminthic. It is anti-parasitic, anti-protozoal. Albendazole, mebendazole. Okay. There is one other drug which is anti-inflammatory, which inhibits depolymerization. Now you are with me for the last time, isn't you? But then I'll come to you in fourth year as well. In internal medicine clerkship during arts gynae, we had classes. One more drug which is anti-inflammatory, which is inhibits polymerization of beta tubulin, used in the treatment of gout. It was only last block, colchicine. Okay. So just a revision of the whole thing. Colchicine, same mechanism. Albendazole, mebendazole, same mechanism. Now we have Vinca alkalides. Paclitaxel is opposite. It inhibits depolymerization. So thus leads to failure in chromosome segregation and cell division. The cell is arrested during mitosis. It fails to go further, either arrest in the Z phase or it comes back to G naught phase. Adverse effects, neuropathy is very, very specific for paclitaxel. Others are common, vomiting, myelosuppression, alopecia. These are common side effects of chemotherapeutic agents. But neuropathy is very, very specific. Methotrexate, we have covered this drug at least 3 times. Anti-metabolite. I hope you remember the definition of anti-metabolite. Yes, tell me. What is the definition of anti-metabolite? Yes, you. No? You are avoiding? Behind it. Yeah. No, don't remember. Does anybody remember? The resemblance is nature, not compound, substrate. Okay, very good. So because of the structural similarity with some of the substrate, it deceives the enzyme, presents itself as a substrate for that enzyme and enters, just like how to say, enters into the metabolic pathway by deceiving the enzyme. So this is anti-metabolite. Methotrexate is resembling what? Folic acid. So enters into the pathway of folic acid metabolism. Which enzyme does it deceive? Dihydrofolate reductase. Okay, so it enters into the middle and becomes a wrong, incorporated into wrong products, which does not have any biological activity. Okay, so this is the same slide which I am showing you repeatedly. Have you seen this slide before? Many times, same. So this step is inhibited by which antimetabolite? Some class of drugs, they resemble PABA. Sulfonamide antibiotics. Okay. Do you remember? Not? Sulfonamides. Sulfonamide antibiotics. Sulfodiazine, sulfacetamide, sulfamethoxazole, sulfasalazine. They are very similar to PABA. If you look at the structure of sulfonamides and PABA, very, very similar. So they deceive dihydropteroid synthase. So they combine with it. So instead of PABA, they sulfonamides combine with stearinine and make dihydropteroic acid, which contains not the PABA, but sulfonamides. Okay. So these are sulfonamides are also antimetabolites, but one step earlier than methotrexate. One more drug, antibiotic, also deceives trimethoprim. Very good. One more anti-malarial drug deceives DHFR. Not Codanon. Codanon is antibiotic. Anti-malarial. I thought you. P. Perimethamine. Okay. Perimethamine. So perimethamine, anti-malarial, methotrexate, immunosuppressant, and anti-cancer, and trimethoprim, antibiotic. So revision of the whole 2 years. Okay. So now you know how, since folic acid, original biologically active folic acid is not incorporated into the activated dihydro or tetrahydrofolate and subsequent metabolites. So the DNA and RNA synthesis is halted. This is the mechanism of anti-cancer activity of methotrexate. Is that clear? Methotrexate leads to myelosuppression that can be prevented to some extent by administering folinic acid or leucovorin. Fortunately, normal cells are quicker to respond to leucovorin compared to malignant cells. Now, once again, $1 million question. Same slide I am sharing with you, which I asked you before, how leucovorin is able to prevent myelotoxicity caused by methotrexate. Good. Can you explain this? Previously, 2 minutes earlier, I mentioned it is not the tetrahydrofolate alone. Various other metabolites of tetrahydrofolate which participate in various as cofactors in purines and perimeter synthesis. Now, tetrahydrofolate that leads to various metabolites. Very difficult to pronounce. 5-10 methylene tetrahydrofolate, 5-10 methinyl tetrahydrofolate, 10-formyl tetrahydrofolate, all are important for DNA synthesis. Now, what you did with the administration of methotrexate, this whole process is blocked. All metabolites subsequent to tetrahydrofolate are blocked. But if you come with some intelligent or some tricky, clever situation, you invent a drug which folinic acid, which very closely resembles 5-10 methinyl tetrahydrofolate. Conceptualize. Suppose it is not folinic acid, since it is very close to 5-10 methinyl tetrahydrofolate. Will it be substrate for dihydrofolate reductase? So that state where dihydrofolate reductase upstream in the earlier events was able to inhibit it because due to methotrexate. But now we are providing with a product which is biologically active and it's not at risk of being inhibited by methotrexate. It's much later. And fortunately, folinic acid, response to folinic acid in normal cells is quicker. So malignant compared to malignant cells. So we can rescue. When we rescue the normal cells, especially the cells of the bone marrow with leucovorin or folinic acids, even though the methotrexate will still continue to work as anti-cancer agent upstream. Did you get my point? It upstream by inhibiting the conversion to tetrahydrofolate, it is still anti-cancer drug without compromising the anti-cancer effect of methotrexate. Leucovorin will continue to rescue normal cells. Because we are providing now a metabolite which is biologically active, but at a later stage. So that's it. The last drug is 5-fluorouracil. Once again, it is anti-metabolite. It inhibits DNA synthesis during S phase by inhibition of thymidylate synthesis and incorporation of its metabolites into RNA and DNA, same like methotrexate, but it resembles a different structure. In the previous case, methotrexate, it resembled folic acid. Now it resembles, can you figure out what is the substrate? Which structure does it resemble to? Thymidylate. So it inhibits enzyme thymidylate synthase, incorporated and synthesis into DNA, which is wrong. And there are some side effects which are non-specific. One specific is hand-foot syndrome. You have heard for the first time. Swelling, the redness, itching of the hands and feet. This is classically known as hand and foot syndrome. Okay, we covered chemotherapy, now hormone therapy. Hormone therapy means mainly estrogen. Okay. So adjuvant hormone modulation therapy is highly, we covered this already. It has been documented that 1/3 of all breast cancers are estrogen dependent and will regress after estrogen deprivation. If you cut down the supply of estrogen, then there will be no more proliferation or growth or division of estrogen responsive cells. Thus, reducing the level of estrogen remains a valuable target for treatment of breast cancer in both premenopausal and postmenopausal women. Now, conceptualize, think, how can you cut down the supply of estrogen? Number one, antagonize the receptors, estrogen receptors. Number two, decrease the synthesis of estrogen. Two strategies. Either imply an antagonist of estrogen receptors or decrease the biosynthesis of estrogen. Okay, so we'll cover both. One is tamoxifen, estrogen receptor antagonist, and inhibitors of biosynthesis or aromatase inhibitors. Okay, SERM, selective estrogen receptor modulator. We don't call it antagonist. Who delivered the lecture on drugs used in female infertility? Atul? Atul. She must have mentioned the drug clomiphene. So clomiphene is another drug, and she didn't mention tamoxifen, but I am not mentioning clomiphene as a treatment of breast cancer, although mechanism of action is very, very close or similar. Tamoxifen and clomiphene. We do not call them antagonist, pure antagonist. We call them modulator. Because at some places, some receptors, these drugs are agonists. At other places, these are antagonists. We can call them modulators or mixed agonist antagonist. Is this a term? Have you heard about this term? Mixed agonist antagonist. Let's revise other. There's one other class in pharmacology. Which one? Anesthetics. Alcohol. Alpha, no. Mixed agonist antagonist is a class of drugs. In another, if you remember neurosciences block, opiates. And I can tell you the name of the drug, pentazocine. Agonist at kappa receptors and antagonist at mu receptors. You forgot. Pentazocine. Okay. This is some selective estrogen receptor or modulator or mixed agonist antagonist because estrogen receptors come in a variety of shapes and structures. How many of estrogen receptors are you aware of? Has anybody told you? Estrogen receptors. They come in a variety of structures and functions and distribution locations. In breast, they are different. In endometrial tissue, they are different. In bone, they are different. In hypothalamus, they are different. Main categories to estrogen, ER alpha, ER beta, and there are subtypes also. ER means estrogen receptors, alpha and estrogen. Did Atul cover? She must have mentioned why we don't call it pure antagonist. We call it agonist antagonist or modulator. There must be a reason. Why do we call it modulator? Because we can't call it agonist, because it is antagonist at another place. We can't call it antagonist as well. So at some places. Do you remember clomifene? Where does it act as agonist and where does it act as antagonist? Antagonist at hypothalamus. Okay. Okay. See the slides. See your slides if you have. If it is antagonist at hypothalamus, then how does it increase the release of follicular stimulating hormone and luteinizing hormone? It's a periphery. It is in the ovaries, it is antagonist. That is why by decreasing the levels of estrogen, it causes the increased release of luteinizing hormone and follicular stimulating hormone. Through this mechanism, it causes the increased stimulation of follicle and causing ovulation. This is the mechanism of clomifene. Am I right? Okay. I don't want to confuse you. Estrogen receptor antagonist, agonist, mixed. Antagonist on breast tissue. That is exactly why do we use in breast cancer. This is the main function of tamoxifen we can use in breast tissue. And agonist on bones and endometrium. Now, Atul must have mentioned what is the major side effect of clomifene in endometrium. Endometrium, hyperplasia may lead to endometrial cancer. Look at this slide. What is that? In clomifene, in case of clomifene, it must be antagonist. It must be. Check. I'm sure it is antagonist. Clomifene is the antagonist of estrogen receptors in endometrium. This is the major difference between tamoxifen and clomifene. Okay. It is antagonist in breast tissue, but agonist on bones and endometrium. This one. That is clomifene is antagonist. That is what I'm telling you. So this is a major difference between clomifene and tamoxifen. Tamoxifen is agonist in the estrogen receptors in endometrium, whereas clomifene is an antagonist. Now, clear? So what did you say was not correct? Okay. Okay. Indicated in ER positive breast cancer, acts as a competitive antagonist on the estrogen receptor. Obviously, when the receptors are antagonized in the breast tissue, it will be useful in ER positive breast cancer. Okay. Uses early stage estrogen receptor positive breast cancers as adjuvant therapy or even metastatic breast cancer in advanced disease, Also, it can be used in ductal carcinoma in situ following surgery and radiation as chemoprevention. Can anybody explain bullet number 3 in DCIS? Why do we use as chemoprevention? Yes, this DCIS may progress to ER-positive breast cancer. So it's chemoprevention, the same as in LCIS, lobular carcinoma in situ, you can use as chemoprevention. Okay, so it is highly, even though it is in situ, it is highly localized. You remove the primary tissue, but then the risk is there that sooner or later it may develop into patient is at risk of developing ER-positive breast cancer. Pathologist must have told you that mention. Okay, and ovulation induction is off-label, like clomiphene. It can be used for induction of ovulation, but this is off-label. For induction of ovulation, it is the clomiphene, which is approved. For breast cancer, it is the tamoxifen, which is approved, but you can still use. Adverse effects, hot flashes, like clomiphene, increased risk of endometrial hyperplasia and cancer because it is agonist at endometrium. This is not seen with clomiphene. Okay, these are the side effects. Another approach is you inhibit the biosynthesis of estrogens. Now, two things. Let me ask you. A woman, premenopausal woman, what is the major source of estrogens in premenopausal ovaries? In postmenopausal, adrenal cortex. The ovaries are suppressed, they are no more secreting estrogens. So in postmenopausal, the major source of estrogen is adrenal cortex. In premenopausal, the major source is ovaries. Now these are two subsets of patients. Premenopausal or postmenopausal. This class of drugs, as the name indicates, aromatase inhibitors. Anastrozole, aromatase is an enzyme which is a member of cytochrome P450 enzyme, which is mainly present in the where ovary or adrenal cortex. In the adrenal cortex. So if you inhibit aromatase, which is P450, which is responsible for conversion from testosterone and various metabolites of androgens into estradiol in the adrenal cortex. This enzyme is responsible in working in adrenal cortex, which is a major source of sex hormones, female sex hormones after menopause. And this enzyme is not operational in ovaries. So who will be the patient in whom you will use in ER, premenopausal ER positive breast cancer patients? Would you use this drug? No use. No use, because the major chunk of estrogen is coming from ovary. So this class of drug will be useful in ER positive post-menopausal breast cancer patients. So aromatase inhibitor reduce estrogen production because they inhibit aromatase. Effective in adjuvant setting for post-menopausal women, important to remember. AIS should not be used in patients with functioning ovaries since they do not block ovarian production of estrogen. Aromatase inhibitors have fewer side effects such as endometrial cancer than tamoxifen. However, they are associated with accelerated bone loss and an increased risk of fractures. These side effects, hot flashes. In the, did you? Okay. Honestly, I don't remember in what contest. Can you open Hatu's lecture? She must have mentioned. In the we have, but if you have, you see, aromatase when in the breast cancer cells, in postmenopausal, where does it come from? Adrenal cortex. And in perimenopausal women, where does it come from? So in the ovaries, you have two sources. It is not only aromatase. Two ways by which estrogen is synthesized. I do not remember if you look at the whole pathway table. So estrogen is not coming through aromatase. It is estrogen is also coming through another mechanism. Can you look at this? Hmm? In this clonal lecture? Estrogen synthesis inhibitors in premenopausal women can be done completely by aromatase inhibitors in premenopausal women. In PCOS, I am totally confused. In PCOS, it is a different ball game. It is a different story. The pathophysiological mechanism is different. In normal, yes. This we are talking about normal or PCOS. I will send an email to the whole class. Yes. Okay. Let's finish it. We covered chemotherapy. We covered how this question. In summary, the question remains: if I rephrase your question, that why aromatase inhibitors are not useful in premenopausal women? Am I right? They are used only in postmenopausal women, and why they are not useful in premenopausal, according to me, according to my lecture. Okay. Very well. So according to my lecture, it's in cancer, why they are used only in postmenopausal women. So why there is a discrepancy? Is that the question? I will address it. Okay. Target therapy these are the drugs which block the growth and spread of cancer by interfering with specific molecules that are involved in the growth, progression, and spread of cancer. Since they are highly specific, selective, keeping in mind the pathophysiology of the breast cancer, they target very specific molecules. They are known as targeted therapy or precision medicines. And one that molecule is HER2. Three? Yes, I have 7 minutes. I will finish before that. So HER2, pathologists and clinicians covered HER2. About 20% of the breast cancers are HER2 receptor positive. And they are associated with poor prognosis, but with the advent of some targeted therapy directed against HER2, we have very useful drugs. They have completely revolutionized the treatment of HER2 positive breast cancers. Okay, we have two classes of drugs. Anti-HER2 receptor antibodies are kept in, which is trastuzumab and pertuzumab and CDK inhibitors. We'll discuss one by one. First of all, Herceptin, trastuzumab. It is an antibody again directed against HER2 receptor, which is a tyrosine kinase. Okay, are you with me? Inhibits growth of tumor cells that overexpress HER2, that leads to decreased HER2-initiated cellular signaling and increased antibody-dependent cytotoxicity and decreased tumor growth. It is antibody directed against HER2 receptor. Now, I am directly going to, then I will come back again. Pertuzumab, two drugs, Herceptin and Pertuzumab, what is the difference? Both are antibodies directed against HER2. Her? No, not half-life. They, okay, let me give you a hint. Given together, both these drugs, both these antibodies, they have synergistic effect. That means from the upfront, they look like having the same mechanism of action, antibodies directed against HER2, but the outcome is different. Therefore, when used together, both these antibodies, they produce a synergistic effect. So since we do not have time, I direct without asking you now, if you are aware about the intracellular signaling events, after binding of ligand with HER2 receptors, what happens? The first event is dimerization of HER2 receptors. HER2 may dimerize with another HER2. This is known as homodimer. HER2 binds with another HER2, homodimer. Or HER2 may bind with another receptor from the same family, especially the HER3. If HER2 binds with HER3, this is heterodimer, and this is the most potent intracellular signaling unit. And the domains on the HER2 are different, which bind to HER2, another HER2, or which may bind to another HER3. So what happens in case of pertuzumab, the epitome for pertuzumab is the domain of HER2 where it binds to HER3, and pertuzumab prevents the HER3 dimer from forming. Up to this level, are you clear? Okay. It binds with a domain on HER2, which is responsible for making a dimer with HER3. Now, in case of Herceptin, or trastuzumab, it binds with a domain which is responsible for making a dimer with another HER2. As I mentioned, the dimers made are different on the same cells. HER2 with HER2, homodimer, HER2 with HER3, heterodimer, most potent. So given together, these drugs may actually produce from the outset, they look at the antibodies directed against HER2. But by looking at the specific binding site, the outcome may be different. So they have synergistic effect. Is that clear? Yes. Okay. So you can see in the previous slide, the most important side effect of trastuzumab is cardiotoxicity in addition to others. So that is why, based on cardiotoxicity, it should be avoided and based to co-administer along with doxorubicin, which is cardiotoxic. Okay. If you have to give it together, then you have to do surveillance. Surveillance is mainly through echocardiography. Last is bone-directed. Those CDK inhibitors are the drugs which inhibit CDK4 and CDK6. These are the kinases which are responsible for phosphorylating another protein. You must have heard about retinoblastoma protein. What is the role of retinoblastoma protein? It is a protein which is responsible for cell cycle progression from G1 to S phase. So an enzyme which is responsible for progression from G1 to S phase, when the phosphorylation of that enzyme is inhibited by this kinase, that means the cell cycle is arrested. Come on, I finished. So the last one you can read on your own, bone therapy. Okay? Thank you very much. I will respond to your emails. I'm done. Thank you.
Doctor, you need the female patient? You need the female patient?
I'm not sure.